implantation technique and outcomes. Dr. Ferrari? I guess just introductions. Ron Parsons from Emory. We have Peter Yu from Yale. And if everybody can just give your disclosures in your talk. Thanks.
Thank you, dear moderators. Good afternoon, everyone. I'm Hirad Pahari from Henry Ford Transplant Institute. I'm going to be talking about robot-assisted live donor kidney transplantation techniques and outcomes. I have no financial interests or relationships to disclose. So robot-assisted kidney transplant is a feasible, minimally invasive option in place of open kidney transplants. And we know that it has been performed in multiple international programs, but primarily within urology-based transplant programs and large robotic centers. In our center, we are mainly performing it only for live donor kidney transplants, but it has been performed for deceased donors in other centers. So in 2010, Dr. Giulinetti et al. From UIC published their technique with left lateral decubitus position and in primarily obese patients, while in 2014, Dr. Menon, who was the chief of urology at Henry Ford Hospital, in collaboration with the team from India, published a different technique with supine lithotomy position, Trendelenburg, with no restrictions on size of the recipient. Important thing to note, were both large robotic experience centers. Studies have reported a short learning curve with this procedure, and we know that multiple European and Asian centers, as seen by recent publications, have adopted this technique with, however, minimal experience in the United States so far. For our robotic experience, our first case was done on May 13th, 2014, using regional hypothermia, using Dr. Menon's previously described technique. As you can see, the first 2 years we had less cases. It has been going up over the last 3 years. And this year alone, within the first 5 months, we have performed 14 cases. So we evaluated our cases from 2013 to the end of 2017, and we compared open versus robotic living donor kidney transplants. The selection of patients were based primarily upon robot availability. Any major concurrent surgeries on the open recipient side were excluded from the analysis. We also evaluated our learning curve in the second part of the study. So very briefly, the pictures, this shows the board placement. Head is down in lithotomy position. This is after exposure of the vessels. The kidney is already here, implantation of the vessels. This is retroperitonealization of the kidney. We put a Humalog clip here. And this one is how the ureteric anastomosis is done. For the incision, for the incision, this is the standard open kidney incision, which is about 15 centimeters in length. Compared to that, you can see only the port side, and this is about 5 to 7 centimeters on the robotic recipients. Looking at our results between the robotic and the open kidney transplants, the recipient age was higher on the open side, but this was not because of any conscious selection bias. The recipient BMI and cold ischemia time were similar, while warm ischemia time was higher by an average of 13 minutes on the robotic side. This was attributable to our early experience, as we will show later in the study. The estimated blood loss and total operative time were significantly lower on the robotic side. The creatinine at 2 weeks, 6 months, and subsequently at 1 year were no different between the two groups, and graft function was excellent in the robotic side. Hospital stay tended to be lower, but it was not significant. Urological complications were similar between the two groups. There were no evidence of fluid collections or lymphoceles on the robotic side, whereas there was also no wound infections or wound disruptions during the period of the study on the robotic side. 5% was the wound infection rate on the open side. Graft survival was 100% in both groups at 1 year. Putting these things into a graph, as mentioned before, the ureteral complications were similar. This is as a percentage of patients. The lymphocyte and wound issues were 0 on the robotic side. The delayed graft function was higher on the robotic side, and this may be attributable to early experience and higher warm ischemia times in the robotic recipients. The renal function in terms of creatinine were similar between the two groups at 6 months and 1 year. We know a lot of study has been done by other centers regarding the obese patients. We just wanted to look at our data to see if something jumped out at us, and we didn't see anything significant when the BMI was more than 30. Very similar pain scores, hospital stay was slightly lower. Wound infection was 0 and 5% respectively. Looking at our learning curve, the most important thing that jumped out at us was the warm time. And this was in our initial 10, it was 61 minutes was the average, whereas in the last 12 was 47, so a drop in more than 25% of warm ischemia time. And this is very similar to as published by other studies. There were 4 DGF patients, which were evenly distributed between the two groups. There were 2 open conversions in the earlier phases. One was because of kidney being put upside down, which we have recently adopted a modification of technique to prevent that, and one was because of a twisted vein which needed to be opened. So to conclude, RAKT is a safe and feasible procedure, even within a novice robotic program like ours. It can be performed with a short learning curve. However, robotic team development is imperative. We have a dedicated team and a dedicated PA for this procedure. We have seen a rapid decrease in warm ischemic times with the learning curve, and our operative times are very reasonable. So to summarize, RAKT is safe with less wound and lymphocyte related complications while maintaining excellent and equivalent 1-year graft outcomes. And finally, future endeavors. We intend to actively expand expertise to other centers by teaching RKT regardless of the type of technique used. We are actually collaborating with a couple of centers already in order to develop a program. We also want to develop teaching courses and further study in the field. And one possible gateway to this technique is by developing the robotic donor nephrectomy and then proceeding to the robotic kidney transplants. Thank you, and I'll take any questions.
Thank you, Dr. Pari, for an interesting paper.
Thank you.
We'll open the